Hi, it's Tammy. Today we're talking about cystitis, and a 26-year-old GO calls the office with complaints of lower abdominal pressure and urinary frequency. She has been in the office 4 times over this past year for dysuria and has been treated for UTIs. She is sexually active and on APRI for contraception. She has a negative GYN history. She feels her UTI symptoms seem to be occurring within 12 hours of intercourse. Past medical history is that she has a history of PCOS, medication she's taking, Loestrin 120, MVIs, and omega 3. Allergy to Cipro. Her vitals were 98.4 temp, blood pressure was 118 over 72, pulse was 84. The initial post, what additional focus subjective visit information would we obtain at this visit? I would ask her how many sexual partners she's had. Is there a new sexual partner? Is she using anything for protection other than the APRI? Any condoms, spermicides? When was her last UTI? How was it treated? Does she feel like the symptoms were ever resolved? Is the dysuria internal or does it burn when the urine passes over her labia? Is she having urgency of urination with her frequency? She already said that she was having frequency of the urination, so I want to see if she's having urgency with that. Any vaginal discharge? Is her urine bloody? Has she ever been diagnosed with an STI? Any flank pain? Any chills, nausea, vomiting, diarrhea, headache, or feeling just blah? What would you include in your focused physical exam? I would look at her general appearance, make sure that she looks healthy, get her vital signs, check for CVA, check her abdomen, look for suprapubic tenderness, and do a pelvic exam, examine her skenes and periurethral glands. What tests would you include today in your patient workup? I would get an HCG, a urine dipstick urinalysis, a urine culture. I read that sensitivity tests are not routinely done unless the patient doesn't improve with the treatment, which she's had them before, but we want to make sure that we're going to treat her with something and see how she reacts to our treatment so that we can have record of that. And then I would grab a CBC. And then it talks about all the patient workup. So her urine was kind of orange colored. Her clarity was turbid. So it goes down and says some things on here. Then it talks about her sensitivities. My diagnosis of this patient is that she has recurrent UTIs or cystitis. The detailed plan of care, diagnostic tests, I would do a cystoscopy to look for cancer or tumor of the bladder, any polyps or overgrowths of normal tissue, bladder stones that could lead to blockage of her urinary tract, scarring or damage caused by frequent UTIs, abnormalities of the urinary tract, or injury of the urinary tract. Pharmacological wise, I would give her macrobid 100 milligrams PO daily times 7 days. I would also consider daily macrobid use if this patient were to get another UTI within a month of finishing her antibiotics for this episode. And then also, I read that there's also a research on a low dose pericoidal antibiotic as an effective prevention strategy. Prophylactic antibiotics commonly used are the macrobid, 100 milligrams once daily. Duration of the prophylactic UTI antibiotics is usually 3 to 6 months, which may be enough time to ascertain and manage underlying predisposing factors. Let's see. Also, the Mayo Clinic, I read, recommends a single dose of antibiotic after sexual intercourse if the patient's infections are related to sexual activity, which this patient seems to think that they are. So this could, she was stating that her symptoms occur 12 hours after intercourse. So you can take an antibiotic 2 hours within intercourse, and that's had some effectiveness. Non-pharmacologically, I'd ask her to increase her water intake, do frequent voiding, make sure that her bladder is empty at all times, and then perennial hygiene. Some women clearly attribute their UTIs to their sexual activity despite their healthy sexual practices, and we just need to make sure that she knows that this isn't her fault. If she's taking good care of herself and cleansing herself well, that some women are just predisposed. Education, including health promotion, disease prevention, how to decrease the patient's risk of recurrence, and what about her anatomy increases her risk. I would tell her to drink plenty of water to dilute her urine and flush out her bacteria, empty her bladder frequently, don't hold her urine in, avoid drinks that may irritate her bladder, avoid coffee, alcohol, and soft drinks containing citrus juice or caffeine until the infection is cleared. She can use a heating pad to decrease the bladder pressure or discomfort. To urinate after intercourse and always wipe from front to back. Explain that since the I would explain to her that since the anus is close to the vagina and this is usually how the infection occurs, that she can do her part by being extra vigilant about wiping front to back at all times. And then sometimes in infection-prone women, the periurethral cells more readily bind E. coli cells than in women who are not prone to infection. Explain to her that this isn't her fault and continue the above suggestions. I would refer her to a urologist if this infection doesn't clear up. And then follow up, she should call or return to the clinic if she's not feeling improvement within 24 to 48 hours, which is what usually happens after you prescribe antibiotics for a UTI. If she feels any systemic symptoms, so like fever, chills, nausea, vomiting, feeling yucky, diarrhea, headache, call or return to the clinic. Also, once this infection clears up, if she wants to try the prophylactic treatment for 3 to 6 months, or if she wants to try the antibiotic, just 1 pill 2 hours after intercourse, I'd be happy to prescribe that for her. And let me see if there was anything else. I think that was it. All right, thank you. Y'all have a good day. Bye.